Okay, welcome to the second session of our Disability Research Center meeting. My name is David Otter. I'm the professor of economics at MIT and the co-director, along with Nicole Maestas, of the NBER Disability Research Center, supported by Social Security Administration, now in this is our 5th annual conference, and we're really proud of the work that's going on and sort of how many good researchers, how many good questions and good students have sort of been brought into the fold of disability research. Our sense is that we're getting a good research return on investment, that SSA is investing wisely. So this panel, our second panel today, is on the effects of the economy and state policy on SSDI outcomes. And this is particularly important in light of the experience of disability applications during the Great Recession. As many of you know, applications rose very rapidly during the Great Recession. Not surprisingly, they too do tend to rise when economic conditions turn down. But actually, the number of people entering the program was quite low by historical standards as a share of applicants. And in fact, some data suggests that the program growth has slowed much more than expected, and we don't know the degree to which that's a change in the composition of those who are applying versus changes in the way that disability applications are being reviewed and screened. So I think this is an incredibly central set of questions for thinking about the trajectory of the disability program and our understanding of where it's heading and what are the fiscal constraints and what are the services that will be provided. So our first paper is on disability insurance in the Great Recession. Our presenter is Kathleen Mullen of Strand Corporation, who's an eminent disability scholar and has done a lot of work with Nicole Maestas, with Alexi Strand, even one paper with myself that may someday be published. And our discussant is, or not, and our discussant is Dave Stapleton of the Mathematica Disability Research Consortium.
All right, that's a pretty hilarious introduction. Thank you, David. So I'm going to be presenting joint work today with Nicole Maestas, who's at Harvard Medical School, and Alexi Strand here, who's from SSA. And we would like to acknowledge our funding from the Disability Research Consortium, which made this research possible. So as many of you know, the Great Recession led to more than a 5 percentage point increase in the unemployment rate nationally, peaking at 10% in October of 2009. And economists have estimated that 40 to 90% of an entire year's output, $6 to $14 trillion, was foregone due to the Great Recession. Other economists, Blyler and Hoynes in particular, have tried to investigate the efficacy of the social safety net in being able to sort of support newly employed workers. And they found counter-cyclical increases in SNAP, which is the Supplemental Nutrition Assistance Program for food stamps, and UI expenditures, and much smaller increases in EITC and SSI. So unlike SNAP, UI, EITC, SSI, maybe it's supposed to be TANF, DI does not explicitly target those with low income or who've involuntarily lost their jobs. It's intended to ensure against a health impairment, the onset of a health impairment or condition that makes somebody unable to work. Not someone who was previously working who lost their job. Nevertheless, as David mentioned in his introduction, there is evidence that DI caseloads are countercyclical. So there's been some work on the effects of regional economic shocks. David and his co-author Mark Duggan have introduced this concept of conditional applicants in their 2003 QJE paper, and conditional applicants are basically disability insurance applicants and oftentimes beneficiaries who do have health problems that qualify them for the program, but they are working with an employer until they lose their job, and then facing the prospect of maybe not being able to find another employer or another job that they could do, then they apply for disability insurance. So it's sort of conditional. The application is conditional on job loss. And of course, there's been a lot in the popular press, a lot of attention to this large increase in claims during and after the Great Recession. And more generally, DI claiming has a cyclical component and has had it for many years. So this is just plotting DI claims in blue and the unemployment rate sort of concurrently at the same time in this dashed gray line from 1992 to 2012, and you can see, and then the gray bars are periods of recession that are dated by the NBER, and so you can see basically that claims do track unemployment rate. So as the unemployment rate increases, you'll see sometimes a little bit afterwards an increase in the claiming rate. So this work that I'm presenting today builds on previous work that we did in a 2015 paper where we basically looked at disability insurance applications and just the initial outcome of those claims, during the Great Recession, and we found a 1.34% increase in DI claiming per 1 percentage point increase in the unemployment rate, using a similar method to the one that I'll describe, for this paper. And then when you multiply that out over the 5 percentage point increase of the Great Recession, we found that Great Recession increased DI claims by 6.7%. But intriguingly in that paper, we found that initial allowances didn't measurably increase. We weren't able to detect an increase in initial allowances. So we were really interested to find out what happens, to these allowances, or what happens to allowances on appeal. So do these denials, do the applicants appeal their denial and kind of track through the disability insurance system, and how many of them ultimately end up claiming DI benefits? So that's what we do in this paper. We track the flow of induced claims from the Great Recession through the disability determination process to see how many of them ultimately made it through. So our research strategy is to regress the number of claims at a given administrative level per state month on the state unemployment rate at the time of the initial filing. So that's all key here. What we're looking at basically is economic conditions at the time of initial filing, and then sort of what subsequently happens to the claim in later months and even years. And by including state and month fix-to-fix, we can soak out common shocks that happen across certain states, maybe more or less likely to claim DI, and then sort of concurrent changes in the time. And then basically what this means intuitively is that we exploit variation in the severity and timing of the Great Recession across states. So different states experience their upticks in unemployment rates at different times, and different states had higher upticks in the unemployment rate. And in a departure from the previous literature, which David might touch on in his comments, we estimate our regressions in level, not log specifications, and actually this is even a departure from our previous paper. And we run unweighted regressions, and this just for the economists and quantitative researchers in the room, this is to impose an adding up constraint so that we can actually literally track, of these, say, 100 new applications, X number were allowed and X number of denied, and then kind of track them out through the system, which is harder to do when you look at log specifications. So here I'm just giving you a picture of our the identifying variation that we use. So as I mentioned, there's quite a bit of variation, both within states over time and across states in the unemployment rate. So this plots the unemployment rate for each state, and each state's its own kind of different colored wiggle, between 2006 and I think this must be October of 2012, just to give you a sense of what we're using our estimates for our estimates. So the data that we use is the universe of initial SSDI claims. So we're using administrative data from SSA, filed between October of 2006 and December of 2012. And then we merge all of these initial claims with reconsiderations in the 831 files and appeals in the case processing and management system, or CPMS database, so that we can basically see what happened to the claims through the system. So just in terms of giving you some summary statistics, this graphic shows you the claims per state month for each of these administrative levels. So the first picture shows you that on average, about 2,666 claims are submitted to each state in a given month. Of those, 1,751 are rejected and 914.3 are allowed. That's in green. And that makes for an initial allowance rate overall of 34.3%. On average, 761 of these denied claims go to reconsideration. Only a small fraction are allowed. Another group go to the appellate level, and let's see if I can go backwards. All right, 100 minus 68.5% are denied or dismissed at that level. So ultimately, we find that 54.3% of all the claims in this database ultimately receive SSDI benefits through any of these levels. So now I'm going to just plot out our estimates of the induced claims by administrative level. So each of these bars are representing basically the regression coefficients. And you can interpret the number as basically telling you, so in this case, this is 144.1. I should have added the numbers, and I apologize for not doing that. Induced SSDI claims or applications for each 1 percentage point increase in the unemployment rate. So as we found in our initial paper, only about 20% of these are allowed at the initial level. And actually in this paper, we do find a statistically significant effect at 10% level. So we basically find that 31 of the 144 were allowed, and 113.5 were denied. So the next step is to kind of look at this. This is actually intended to be a red bar, and I'm really sad it's blue because it looked much nicer in my slides. But of the blue claims, so the denied claims, we can see quite a number of them arriving at the reconsideration level. So we estimate that 70.6 of induced claims at the reconsideration level by a 1 percentage point increase in disability insurance applications. Of these, only 7.7 or 10.9% were allowed at the reconsideration level, and the rest were denied. So most of the action is not surprisingly happening at the appellate level. And then many of you are also very familiar with the system and know that there's prototype and non-prototype systems. So a lot of applicants actually skip through the reconsideration stage and they go straight to the ALJ process. So here I'm just kind of lumping them all together. And basically showing you that, let's see, what is it? 43% of the initial denials ended up, at the appeals process. So that's 56.4 is our estimate there. And then of these, I should have this number, and I don't. Maybe it's 43% are allowed and denied. This is why numbers are better than graphs or stars. But all told, in the end, we actually estimate that 52.3% of induced claims, end up on the SSDI rolls. So, the number is basically 63 out of the 144.1%, and that's actually statistically significant at the 1% level. So, let me just numbers. Okay, so there was some kind of mistake, I guess, in translating this to the system here. So in the end, our initial paper found that basically about 20% of these induced claims, were actually allowed at the initial level, but 52.3% of them made it on, if they were sort of persistent enough to go through the process. So one thing we were really interested in thinking about this time period, not just the Great Recession, but that it coincided with a period of increased attention to try to give feedback to administrative law judges, information about the claims that they were adjudicating and sort of how they did, how well they sort of fit with the program. So the intent, I think, was to decrease allowance rates at the administrative law judge level, which were pretty high over this time period. So, but, of course, this happened right around the time of the Great Recession, and it wasn't rolled out, as far as I know, in a randomized, controlled fashion so that you could actually, estimate the effect of this reform. So, while some people were saying, look at this decline in allowance rates at the appeals level over this time period, this must be an effective program, this also, of course, coincided with this increase in applications from the Great Recession, which one might reasonably expect would be sort of marginal in terms of their ability to qualify for disability insurance benefits. And so you might expect a lower allowance rate just by the change in case mix. And so indeed we find that when you look at the initial allowance rate and the appellate allowance rate overall and for our induced applicants, so that's just implied by our regression coefficients, you see that the induced applicants have a much lower probability of receiving benefits over this period. So we actually did just a back-of-the-envelope calculation to try to sort of come up with an estimate of the counterfactual allowance rate at the appellate level if you were to basically take out the induced applications from the Great Recession and just look at the allowance rate for those who ultimately made it through the system. So here, the green line is showing you the actual allowance rate for the appellate level between 2007 and 2012, and the orange line is showing you the our sort of simulated allowance rate if you were to take out the induced claims from the Great Recession. So, holding the case mix constant across these two groups. And so you can actually see that, in our simulation, that the allowance rate would have, kept rising a little bit up until 2009, and then you would have started seeing a sharp fall in allowance rates over this time period, and then eventually they start to, the Great Recession kind of peters out, and then the two rates kind of come together. So, of course, that's not, a rigorous evaluation of this program, but it is, giving some evidence to the fact that there could be, something going on with the way that the appellate judges were adjudicating the cases. Not just changes in case mix that are happening over this time period. So in summary, we find the Great Recession induced both allowances and denials at all administrative levels. And these induced claims were more likely to result in denial than the average claim at any of these levels. I just showed you that without the induced claims, we find the allowance rate at the appellate level would have increased through 2009, and then would have started to fall by more than 20 percentage points between 2009 and 2012. So I think I will leave it there with a minute to spare. So thank you very much. I stole this.
Oh, okay. Oop, there. So about 25 years ago, several colleagues and I conducted an analysis of the causes of recent growth, recent at that time anyway, of SSDI applications and awards. And the primary question that we addressed was what was the effect of the 1991 recession on applications and awards. Now, prior to our research, there was much debate about whether recessions had any effect on applications and especially on awards. After all, as Kathleen indicated, SSDI is a program for workers who can no longer work substantially because of medical reasons, not because they've been laid off. But we showed definitively that there was, in fact, a substantial impact on applications. However, we also found that the percentage effect on initial awards was much smaller and not statistically significant. But because of technical limitations in our analysis, I have long suspected that our results substantially understated the impact of the recession on both applications and awards. After accounting for changes in labor force demographics as well as the recession during that time, our analysis left essentially half of the SSDI application award growth of the early 1990s unexplained. And that unexplained growth has been attributed to a variety of other unquantifiable factors, and somewhat controversially to the Social Security 1984 amendments, the Social Security Act, and also to the 1990 Americans with Disabilities Act. And I think that the finding that the recession's effect was relatively small, particularly on awards, may have increased emphasis on the possibility that these other factors had an important effect on award growth during that period. And so it's entirely possible that if we understated the effect of recession on the awards during that period, that the importance of these other factors has been understood to be larger than it really was. So I think Kathleen and her collaborators have had a much better opportunity to study the effects of the business cycle on SSDI applications and awards. And one thing about the Great Recession is that it was a great natural experiment. So they had a chance to look at this much greater natural experiment than we had in 1991. They also had much richer data to look at, and they've also used the data to produce a number of new and interesting results. And I think everything that she's presented looks pretty solid to me, and I think is very interesting. The rest of my comments should not be interpreted as suggesting that they're not, and or take anything away from what they've accomplished. But ultimately, when I finished reading the material, I was left with the same nagging suspicion that I had about my own work in the past. That is that their model, like ours, did not fully capture the effects of the business cycle. And the primary reason for that has to do with the dynamics of the business cycle effects. And my guess is that a well-specified dynamic model would find much larger effects than they had, and that's what, that would have important consequences for the interpretation of the growth in the recent period. So let's consider the dynamics for a minute. So when a downturn occurs, workers get laid off, and some of those workers may go on and apply for SSDI right away. Mark Duggan and David Otter have called these contingent applicants. They don't apply when they're working. They have a medical condition already, but they lose their jobs and they go ahead and apply. But contingent applicants don't necessarily walk into a field office the day after they leave their jobs and apply for SSDI, or even do it in the next month or after that. In fact, many will become eligible for unemployment benefits as long as they say they're able and willing to work. And it's common practice for policymakers during a major recession, as certainly during the Great Recession, to extend the maximum duration of unemployment benefits. So many contingent applicants may hope they're going to get called back to work, or may genuinely search for work for an extensive period, but then eventually give up, and possibly after their medical condition further deteriorates, and at that point apply for SSDI. But I think it's really important not to assume that they follow a stylized path from medical onset to job loss to DI application, which I think is implicit in much of our modeling efforts. So in fact, we know that this stylized path is not the norm for SSDI applicants in general. Cara Contrari, who you heard earlier from, and several co-authors recently completed a study in which they looked at the employment history of SSDI applicants, and they found that fully half of the applicants were either not employed at all in the 24 months before they applied, or were employed just very intermittently. They had really weak attachment to the labor force. And I think there's a good reason to believe that contingent applicants are more likely than other applicants to have an extended period of time without regular employment prior to application. So there are three important facts that are reported by Kathleen and her co-authors that I think are consistent with this expectation. Most directly, they found that, I think I've got the slide here. Let's see if I can get it up. Not doing anything. No, I put it in separate. Yeah, so here it is. They show that they look at the median months from the alleged disability onset. By the way, I think this was from the earlier paper, that increases with the employment rate. As demonstrated by this chart, which shows the plots of the median duration to application and a smoothed function for that, and the unemployment rate against time. So you can see that median duration goes up with the size of the unemployment rate, although with a bit of a lag. Second, longer delays in claiming would also help explain why in the last 3 recessions the peak of applications occurred 12 or more months after the peak of the unemployment rate. And this is another chart from her presentation today, to which I've added something, I hope. Well, we're not getting there. There it is, okay. Pretty good delay here. So the red, you saw this chart earlier, but the red arrows which I've added show the duration from the peak of the unemployment rate to the peak of claiming. And that again suggests to me that there are a lot of delays in the claiming of those who experience a layoff. The final fact from their analysis is from their analysis of the sensitivity of the unemployment rate coefficient in their regressions for claiming to replacing the current value of the unemployment rate with lag values of varying lengths. And maybe I'll get this one up there, maybe I won't, but what it basically shows is if you, instead of using the current value of the unemployment rate, if you use the lag 1 month, lag 2 months, right up to lag 10 months, your variance explained is just as high. After that, it tails off. And that, to me, suggests that it must be that the effect of the claiming is partially delayed. I'm sorry, the effect of the recession is partially delayed. What I would like to do is to encourage Kathleen and her colleagues to consider the possibility that their estimates substantially understate the effects of the Great Recession on applications and awards. And as a first step to doing that, I think they could determine the extent to which their model, along with labor force demographics, can explain the growth in applications and awards on the heels of the Great Recession, My guess is that that exercise, like the one we conducted 25 years earlier, will find large residual growth in the years immediately after the recession, growth that could plausibly be explained by the recession, but is not captured by the current model. Second, I also would recommend that they estimate models with multiple lags of the unemployment rate, not just the contemporaneous one or single lags, using a polynomial or other sort of smoothing technique. This is something we did with success in modeling AFDC caseloads way back in prior to the welfare reform period, and we found that the impacts of the recession gradually occurred over 8 quarters, and were maximized when we looked at 8-quarter lags, not just a single lag. And alternatively, and perhaps this would be more simple, but I'm not sure that they can do it, they could date applications instead of by the application date, by the alleged onset date. And to my mind, that might provide stronger evidence, because I suspect the alleged onset date is more strongly associated with the date of layoff than is the application date. I would also consider replacing the unemployment rate measure with other business cycle indicators in their analysis, such as job loss or monthly unemployment claim measures. Everybody knows, as I know you do, that the unemployment rate is a pretty crude measure for purposes of modeling business cycle effects because of the well-known discouraged worker effect. The unemployment rate only goes up to the extent that workers who lose their jobs stay in the labor force and continue to look for work. So it doesn't fully capture the extent of job loss. And in fact, based on the unemployment rate alone, it's tempting to think that we've already fully recovered from the Great Recession, but I think few economists would say that's true. They would point out that the age-adjusted labor force participation rates today are far lower than they were in 2007. Finally, I think it would be also worthwhile to consider specifications that really capture the idea that a substantial share of claims that are induced by a recession are from workers who were on a path to claiming at some time in the future anyway. So instead of really inducing them to claim, it just accelerated their claim. And the result of that is that later on, when they would have claimed in the absence of a recession, they're already in SSDI. They don't have to claim again. And so claims are going to go down, right? That's going to lead to a decline in claims. And I think models like that would have dynamic effects that are asymmetric. And so I think that's an important feature of the modeling that needs to be considered. Ultimately, this is really important work for a number of different reasons. First of all, the effects of the business cycle affect trust fund projections, and those tend to drive the policy debate about SSDI. Secondly, as I indicated in my earlier remarks, that our understanding of how the recession affects applications and awards also has implications for what we think the other factors affecting applications and awards are. And if we miss how important the recession is, then we're going to also overstate the importance of other factors. And finally, I would like to just indicate that the fundamentally most important reason to my mind is the substantial business cycle effects on applications and especially awards raise really serious questions about the design of public policies to support workers with significant long-lasting medical conditions. If many of our SSDI beneficiaries are essentially workers who could work and have a medical condition, and they were working and were induced to apply not because they were laid off for reasons not to do with their medical condition, then that suggests to me that we need to work on designs for programs that really help these workers stay in the labor force, where I think they will be better off. And also, it would at the same time reduce taxpayer expenditures. Thank you very much.
Great. Okay, that was a terrific paper, and that was a lot of discussion as well. I mean, David implicitly wrote several papers in the course of his discussion. So good. So our second paper of this panel is equally momentous, talking about the relationship between controlled substance use and disability insurance. In particular, we're speaking of the opioid crisis, and many people are asking how much is the opioid crisis, is that a mirror of the general poor economic health and poor and low well-being of the disadvantaged population in the United States? To what degree does opioid usage lead to disability enrollment? To what degree does the medical benefits associated with disability enrollment support opioid use? So these are very important questions. Susan Stewart, who is a PhD researcher at the National Bureau of Economic Research and has a PhD in gerontology and public policy from USC, will be speaking on her joint work with David Cutler and Ellen Meara. And our discussant is Stefan of the University of Calgary, who is also a person who's done important work on disability insurance and health.
Thank you. David Cutler is here, and Ellen Meara, who's published several papers on prescription pain medication use, cannot be here today. But I'm happy to present this work on opioid abuse or opioid use and how it's related to SSDI and SSI enrollment. Where's the clicker? Do you have the clicker? Oh. Height challenged. Okay, so the study is motivated by two main facts. Unfortunately, chronic pain is a very common and persistent problem in the US, and it's also the top cause of SSDI enrollment. And as we know, there's been a huge increase in opioid pain medication use in our country. And so our question is, what is the impact of all this pain medication on applications and enrollment in SSDI and SSI? So here's just a picture of the dramatic increase in the distribution of opioid pain medications over time. And a often cited statistic is that there are enough opioids prescribed in the US for every adult to have about one prescription per year. I'll show more shipment data later. So which way could opioid use influence applications? Hopefully, ideally, we would want the increased pain relief to lead to a greater ability to work and therefore fewer applications for SSDI and SSI. But there's also the fact that people may enroll in order to have prescription coverage for the opioid medications. And most unfortunately, if the medications, and we're seeing evidence that they're not giving the kind of pain relief that was initially promised for long-term chronic pain, and they do have a high risk of addiction. So if people are will go up more on DI because of the incomplete pain relief and also factors associated with the addiction. Addiction itself cannot be a reason to go on DI, but as we know, it can lead to a spiral of a lot of problems that could lead to application. So to look at this question, we did two types of analysis. We had aggregate data at the state level. And I should just mention that I say DI as a shorthand, and I always mean SSDI and SSI. We looked at people applying for or enrolled in one or the other or both as an outcome. So the state level data looked at changes in the availability of medications, in shipments of medications, and then state level applications. And the microdata had individual level enrollment data. So I'll talk first about the aggregate analyses. So the opioid availability that I showed earlier, so because they're a controlled substance, the USDA has to track shipments of all opioid medications, so they have information on these shipments to states over time, and it's given in terms of milligrams of morphine equivalent, since different medications have different levels of opioids in them. And we translated this into rates by dividing by the resident state population age 16 plus. So we have shipment rates, and another measure of drug use that we have from work that Ellen has done in disabled non-elderly Medicare beneficiaries are rates of high opioid use, and that's defined as taking this dose daily in any calendar quarter. So we look at that as a percentage of disabled Medicare beneficiaries in the state who are taking these high doses. So these are quite different measures of opioid use, and they're moderately correlated. And then for SSDI, SSI applications, we were grateful to receive from Alexis Strand application rates in each state, or counts of applications in each state in each year. And I should note that these are applications based on state of residence, not where the application was processed, to get around the situations where applications are sent to another state for processing. And we normalize those into rates by dividing by the population that was most likely to apply for DI, age 45 to 64. So in looking at this, it's important to consider the fact that opioid availability is not exogenous from pain. And if opioids are just going up because pain is going up, then we would of course expect DI to go up also. So we have to consider measures that might help us to determine that it's exogenous. So one thing that we have is that states have been quite different in their cracking down, the timing and the extent of cracking down on fraudulent providers. So we know that, for example, especially Florida is the most dramatic example, where there was the dramatic increase, which I'll show, and then a crackdown on what's called pill mills, and we see a dramatic decline post-2010 in both supply and in opioid deaths and other measures. So that is an important instrument that we can use that we know is not related to pain to look at the effects of opioids. Another instrument that we haven't considered yet, but that will be useful to consider, is the share of the population who get their prescription coverage through Medicare Part D, because that's been shown in a recent NBER working paper to have spillover effects in the wider population. So here we have just a demonstration of the variation across states in shipment levels. So this is much wider variation, like a five-fold variation, much wider than we would expect to see in pain, or than we do see in pain. So here's the little thing didn't come out, but the state that goes up, you can all guess, and then crashes down in 2010 is Florida, and that reflects the cracking down on the pill mills in that state. So the middle line is just the average, again, that you saw before of shipments across states, and the lower line is Illinois, which had a slower growth over that period. So this just demonstrates with two extreme states how we can use that variability. Oh, here's the one with the crackdown. Okay, so a first look at the relationship between DI applications and supply. We just divided states into either low or high shipment states based on where they were relative to the median, and we see that both sets of states had similar patterns, but there was a modestly greater increase in the states with more opioids. So here we have a plot of change in the log of applications versus the log of shipments, and it's not dramatic, but it is in a positive direction, and there's some variation across states. And here we have similarly for the application rate versus the proportion of the state with high-dose opioids, people taking a high dose of opioids. So here we see the same thing in regression form, and we see the effect of controlling for things that we would expect might have an effect, such as GDP per capita in the state and the housing price index, and we find that either both before and after those controls, there is a positive effect of shipments, but it's not significant. But we're not seeing a negative effect, i.e. we're not seeing the opioids improving or bringing down DI applications. So here we have I just have to double check what we have. Scatter plot, and we're looking at change in availability over two different time periods. So we can see that states that had a change in shipments, an improvement, like I mentioned Florida in the bottom circle over time. And then we can see the higher circle shows states that had consistently high rates over both periods, and those happen to also be the states with high opioid death rates. Whoops. Here we did a difference in difference analysis and found that there is a positive and significant effect, meaning that in states where opioid shipments increased a lot, we had a higher increase in DI applications, and in states where opioid shipments did not increase a lot, we did not have an increase. So that's stronger evidence for, unfortunately, a negative effect of opiates. Now I'll move to our analysis of the microdata. So here we use data from the HRS, which allowed us to look at individual reports of enrollment, this time not applications but enrollment in SSDI and SSI. And I mentioned here questions on pain and pain meds, and this is something we're going to look at as an individual measure of use, but we don't have specifically whether they were taking opioid pain meds, and we're still looking at that, but at this point what we used, even with the microdata, was the macro levels of shipments and of rates of high dose use in the state. And we also have, we have the HRS geographic data, which allows us to link those. So we started off with full-time workers. We wanted to start off with people who were working and were not in pain at their entry, and we didn't follow them. This wasn't a longitudinal analysis, but we looked at their baseline. At the baseline, they were working and not in pain, and we looked at their baseline characteristics like BMI and smoking, and then we looked at how they were in the labor force by the wave before they turned 65. And the shipments in this analysis were state average shipments, so we just adjusted for, because they're fairly correlated over time, shipments within a state. We just adjusted for year trends and used a single measure of state shipments for each state in this analysis. So the results show that significantly there was a larger share of people enrolled in disability insurance in states with greater opioid use. And just to give you an idea of the magnitude of this effect, if we simulate a 1 standard deviation increase in shipments, that leads to 3% more people on SSDI and SSI, and that's compared to 9% on it, so that's a pretty big effect. So in conclusion, we are not, unfortunately, seeing evidence of opioid medications reducing people's disability or their applications or their enrollment. This is just preliminary, so we have to be careful about drawing conclusions, but there's not evidence that these opioid medications are helping middle-aged folks to stay in the labor force. And we're going to continue to look at this with a variety of data and techniques and focus more on the exogeneity, which is an important issue in this analysis. So thank you.
Okay, thank you very much for the opportunity to discuss this paper, which I enjoyed reading a lot. So some of my comments, as I saw in the presentation by Susanna, some of them have already been addressed, and they were not addressed in the version of the paper I had, so I'm glad to see that. So let me summarize in one slide what this paper does. So they look at the question they're asking is whether the expanded availability of opioid medication affects application and enrollment in the SSDI and SSI programs. As the authors point out, theoretically it's not clear what the relationship should be. On the one hand, you could think that these drugs may help people to reduce the pain and which may reduce their tendency to apply for disability benefits. On the other hand, they might become addicted to these pain relievers and which could deteriorate their health and work potential, and this could increase the tendency to apply. And so to address this question, they exploit state-level changes in the availability of opioid medications over a 15-year time period. And so let me first stress, I think that this is an extremely important research question. As Suzanne pointed out, musculoskeletal conditions, including back and neck pain, arthritis, and related maladies are the most common conditions leading to people to enroll into SSDI and SSI. And interestingly, in a recent paper by Ann Case and Angus Deaton in Brookings' paper, they also show that among white non-Hispanics, low educated, the probability or the fraction of people that are reporting pain has been increasing substantially with younger birth cohorts. So at the same age, if you look at younger birth cohorts, you see that they're way more likely to report that they're in pain. And so many of these individuals may end up consuming opioid drugs, and if there is this link between SSDI and SSI enrollment and opioid drug use, that this could have very important implications for SSDI and SSI in the future. Also, I think it's an important question because in general, there's very little research on effects of medical innovations on disability enrollment and labor supply. And perhaps the most closely related evidence that we have is from COX-2 inhibitors. So this is drugs against inflammation and pain as well. And one of these drugs, Vioxx, has been taken away from the market in 2004 because of potential harmful side effects. And a paper by Craig Garthwaite in the US shows that when this drug was taken away, that this decreased labor supply among older workers. And in a recent paper for Norway, they also showed that this removal of this drug increased DI enrollment in Norway. And so I think an interesting question here is that the authors maybe could try to exploit a bit more or address more is, why do we see differential effects for COX-2 inhibitors and opioid drugs? Both are, in a way, should reduce pain. And so I think to look at this a bit more, it would be interesting to drill down and look at effects on labor supply. Suzanne did that a little bit, but maybe also look at health, the health effects of these drugs, and try to expand it a bit for all age groups, not only the older workers. And I think an interesting effect that they also find is that there is an increase in SSDI enrollment, which is interesting in a sense because chemical dependency is not a qualifying condition. And so you might think that there could be an increase in applications, but these additional applicants might not qualify for benefits, so they might not end up on the SSDI rolls. And so I think here would be really interesting to see what are the conditions, the qualified conditions that people end up with on this program. Not only, like you discussed, you show that there is an increase in enrollment, but I think it would be interesting to see what conditions they enter the program with. As you pointed out, I think the key empirical challenge is are these changes exogenous in the availability of opioid drugs? And in particular, one concern is that you would think that states that have very high opioid drug use and the application trends are way more likely to adopt stricter laws. And so you would ultimately compare states with very different trends in opioid drug use before these changes, and this could bias your estimates. And so I think that's sort of the challenge you have here. And so, but you have many years of data before for a long time period, so you could try to look a little bit more at these trends in opioid use before they adopted these stricter laws. And if you see that these trends are indeed different, that maybe you try to zoom in on states that are more similar in these trends. A second challenge is that you have all these different law changes across these states, and that they affected the shipment of these drugs. And one question was, to what extent are they comparable? I mean, these across states. And I think one interesting policy experiment that you have, and maybe you already went a bit in this direction, is that in 2010 there was this introduction of the abuse deterrent version of OxyContin, which was one of the largest opioid drugs. And in a recent paper by Alpert, Pakula, and Powell, what they show is that this change in 2010 systematically reduced opioid drug misuse and opioid consumption. And so you have this sharp change in 2010. And in addition, what you also have is that there is very large geographical variation in OxyContin use before 2010 across states. So let me show you this here. In this table, you see that, for instance, rates of OxyContin misuse are much higher in Rhode Island, West Virginia, and Utah, but significantly lower, very low in Illinois, South Dakota, and Iowa. And so what you can do is essentially to look at this question, what would be interesting is to compare these, exploit this geographical variation and essentially compare high use states with low use states before and after this change, and see whether in high use states you see a significant increase in DI applications and enrollment relative to low use states. But in sum, yeah, I think it's a great paper, and thank you again for the opportunity to discuss it, and I look forward to seeing it published. Thank you.
Great. If I can also just offer one comment on the paper, I think that one hypothesis we should bear in mind is that both rising opioid abuse and rising disability in states maybe have the same underlying cause, may be reflective of kind of poor economic and other conditions there, and that they could be, you know, simultaneously determined. So I don't know if we want to say, based on this really important evidence, I don't think we can't necessarily draw the causal arrow in either direction, but we should be thinking about the constellation of circumstances and asking where it begins. This third paper is on an essential question in disability policy, which is programs that may be effective in maintaining employment and independence and deterring people from needing to go on to long-term disability. And this work by Judith Cook, who is a professor of psychology at the University of Illinois in Chicago, will discuss a program in Texas that has worked on this. And her discussant will be Crystal Blyler, who is also a PhD psychologist at Mathematica.
So I'm very pleased to be here today to present the results of our long-term follow-up of the Texas demonstration to maintain independence and employment participants. I'd like to acknowledge my two co-authors, Dr. Jane Burke-Miller of UIC and Professor Tom Bohman of UT Austin, as well as the funding we received from SSA through the DRC that allowed us to undertake this research. The DMIE demonstration was authorized by the Ticket to Work and Work Incentives Improvement Act and was overseen by the Centers for Medicare and Medicaid Services in 2006 through 2009. It awarded funds to 4 states to create, mount, and study interventions for workers with potentially disabling health conditions that would help them avoid entering the SSI and DI roles. The demonstration allowed states to provide health insurance coverage equivalent to their standard Medicaid benefit package or wraparound coverage to supplement public or employer-sponsored coverage. States also had the option to offer vocational and case management services. In Texas, the DMIE project was called Working Well. It was designed to address the health, vocational, and social needs of employed adults who were deemed to be at risk of disability. It used a person-centered approach incorporating motivational interviewing, increased access to health care and employment supports, and a case management model that integrated clinical and vocational services. The approach was designed to improve recipients' physical and mental health, enhance their quality of life, and promote sustained employment to delay or avoid application for federal disability benefits. Each DMIE site chose a unique target population. Texas identified working adults aged 21 through 60 who were employed at least 40 hours per month, but who lacked access to employer-sponsored health insurance and whose income fell below the federal poverty level. Another inclusion criterion was a diagnosis of either serious mental illness or a combination of a behavioral health condition with a physical health condition. They could not be receiving Medicaid and could not currently have applied for or been certified eligible for SSA disability benefits. Participants were all enrolled in the Houston area Harris County Health District, which was a state-funded entity providing Medicaid-like health services to medically indigent individuals on a sliding scale basis. I won't go into the details about what the larger demonstration found, but regarding the SSA disability beneficiary status, in Texas, after 12 months, a significantly lower proportion of intervention participants than controls were receiving SSI or DI. However, the difference was fairly small, about 2 percentage points. Regarding employment, there was no significant impact on earnings or likelihood of employment at the Texas site or, in fact, at any of the sites. This may have reflected the requirement of the overall study that all study participants be employed at enrollment, so changes on that outcome were possible only through job loss, which was a relatively rare event, all of which points to the need for a longer follow-up period. Thus, the purpose of our project was to assess the longer-term effects of Texas's DMIE services over 5 years of post-intervention follow-up from 2010 through 2014. The outcomes we targeted were employment status, healthcare utilization, which we assessed as any outpatient services, any pharmacy services, and any inpatient or emergency department services, which we combined because of low frequency, as well as Medicaid eligibility due to disability. As I'm sure you can imagine, assembling the data for this follow-up, which was unplanned, was quite challenging. It took multiple years and multiple subcontracts and IRB approvals from multiple IRBs, and we really appreciate SSA's patience as the years went on, and I'm sure they wondered if they would ever see anything from this study. We had access to the original evaluation baseline data through Dr. Bohman. We also accessed the Harris County Health System's Indigent Care Health Services claims and utilization administrative data. The Texas Workforce Commission provided us with quarterly employment and wage information. And finally, the Texas Department of Health and Human Services provided monthly Medicaid eligibility and reason for eligibility. 1,616 participants were randomly assigned to the intervention or control condition, and there were no differences on baseline characteristics. The average participant was 48 years of age, 3/4 were female. The group was predominantly of racial ethnic minority status. Around a third had less than a high school education. Only a quarter were married, but the large majority were parents. Just over half worked in sales or service occupations, and the average household income was about $18,000 a year. 57% of participants had a combination of mental health and physical health diagnoses. 17% had mental health, physical health, and substance abuse diagnoses. 15% had physical health and substance abuse diagnoses. 8% had serious mental illness diagnoses, and 3% had serious mental illness and substance abuse diagnoses. Physical health diagnoses included, for example, diabetes, hypertension, heart disease, and asthma. Intervention participants received a minimum of 15 months of intervention exposure and average 21 months of exposure. Regarding our follow-up, there was an average of 24 months or 2 years between the time people enrolled in the demonstration and the start of our study's long-term follow-up period, which was January 2010, with no difference between study conditions. However, it's worth noting that given our data sources, loss to long-term follow-up due to death, relocation, or other reasons couldn't be ascertained. This slide shows unadjusted outcomes over 5 years combined. Only about 15% of both study conditions had any outpatient services, so no differences there. On the other hand, the large majority of both conditions had pharmacy claims, above 80%. With a higher proportion of the intervention groups than controls using pharmacy services. About 8% of both conditions had inpatient or emergency services, and about 18% of both groups were ever Medicaid eligible due to disability. A slightly higher proportion of intervention participants had any earned income over the follow-up, a difference of 4 percentage points that fell just short of significance. We addressed the problem of uncertain loss to follow-up status by adjusting for baseline characteristics in multivariable models and by analyzing the outcome data in 3 ways. These included looking only at the first year of long-term follow-up, which was 2010. Next, we looked at all 5 long-term follow-up years combined. And finally, we used longitudinal models that included time and time-by-study condition interaction effects. We also conducted an additional subgroup analysis limited to participants with serious mental illness. This slide presents the results of multivariable analyses of our 3 types of health service utilization. These were examined in the first year of follow-up alone, Model 1, all 5 years combined, Model 2, and longitudinally by year, Model 3. Models controlled for gender, race, ethnicity, education, marital status, occupation, age, recruitment location, and time since study enrollment. In all 3 models, there is no evidence of a study condition relationship with outpatient services use. On the other hand, we did find a significant study condition effect in our model predicting pharmacy services in the first year of follow-up and in all years combined. This also occurred for the longitudinal model, but the p-value fell just short of significance. And again, the intervention participants used more pharmacy services. And finally, there was no relationship between study condition and inpatient or emergency room services in any of the models. Next, we turn to the outcomes of disability status and employment. In models 1, 2, and 3, there were no significant effects of study condition associated with disability or with employment status. However, there were effects of time alone in the longitudinal models. Both the likelihood of disability and the likelihood of employment decreased each year significantly. So in comparing our longer-term follow-up results to the original demonstration results, a few things are noteworthy. In the original Texas evaluation, more of the intervention group than controls used outpatient services, a difference we did not find in our longer-term follow-up. The original evaluation did not assess pharmacy services utilization, but intervention participants did report significantly less difficulty accessing prescription services than controls. This may have been related to our long-term follow-up finding of higher pharmacy service utilization among intervention participants. Finally, in both our evaluation and the original evaluation, there was no study condition difference in inpatient or emergency room services. A notable finding of the original evaluation was that intervention participants were less likely to report new SSI or DI benefits than controls, whereas we found no difference in disability status by study condition. And finally, the original evaluation did not find a difference in employment outcomes, while we found only a marginal difference, and this disappeared in the multivariate analysis. However, one aspect that distinguished the Texas site was the high proportion of study participants with behavioral health disorders, particularly serious mental illness. This slide presents the results of a subgroup analysis looking at service utilization for this subgroup. In all three models, there is no evidence of a study condition relationship with outpatient services use or inpatient emergency services use. However, regarding pharmacy services, in Model 2, intervention participants have a significantly greater likelihood of use of pharmacy services in the 5 follow-up years combined, and in the longitudinal model, the odds ratio is even higher, but only approaches significance. Next, we see the subgroup analysis results for the remaining 2 outcomes. These are Medicaid eligibility due to disability status and likelihood of employment. There are no significant findings for the disability outcome. However, we did find a significant effect in the longitudinal model for any earned income. Here, those participants with serious mental illness who received the DMIE intervention had a significantly greater likelihood than controls of being employed, with an odds ratio close to 5. In the interest of time, I'm going to skip this next figure and go on to figure 2. Here we're looking at observed unadjusted employment status over the long-term follow-up years from 2010 through 2014. The 4 lines represent the different combinations of study condition and severe mental illness. We just saw from our multivariable analysis that among the subgroup of people with severe mental illness, those who received the intervention were more likely to be employed. And we see that illustrated here by the fact that the group with the lowest employment status is the control condition subjects with serious mental illness. Those in the dashed line at the bottom of the figure, they were the least likely to be employed over time. The intervention group with serious mental illness shows an employment pattern more similar to the 2 groups that did not have serious mental illness, and that's the group in the solid line that, as you can see, is clustered close to the lines for the 2 non-serious mental illness groups. So what can we make of these findings? Taken together, our results offer fairly minimal support for the long-term effectiveness of early intervention services. Compared to controls, intervention participants in Texas were no more likely to be employed, they were equally likely to be eligible for Medicaid due to disability, and they showed similar patterns of medical service utilization, differing only in pharmacy service use, which was higher for the DMIE intervention recipients. However, in the subgroup analysis of those with serious mental illness, the positive effect of the intervention on prescription drug use persisted, And in addition, there was a significant association of study condition with greater likelihood of employment. We also saw that although intervention participants with serious mental illness had lower levels of employment over time than those without serious mental illness, regardless of study condition, they still were considerably more often employed than control participants with serious mental illness who did not receive the early intervention services. This raises the intriguing possibility that early intervention services may be especially valuable for this vulnerable group. I want to point out several limitations to our study. First is the unknown status of participants over the study period in terms of loss to follow-up. While this is certainly a weakness, there's no compelling reason to expect that loss to follow-up was associated with study condition, given that the administrative data were used exclusively. Second is the small number of participants in the serious mental illness subgroup, 177. Because of this, analysis of outcomes with a low prevalence may have been underpowered. And third is the fact that, like all the DMIE sites, Texas's study population was uniquely selected and therefore not necessarily representative of the larger employed adult population with potentially disabling conditions. While our results offer minimal support for the long-term effectiveness of early intervention models, it's also true that there have been changes in the 10 years since the DMIE in federal policies regarding both healthcare coverage and employment services that could alter the context in which these models could operate today. Given the initial positive results of the demonstration, along with some evidence from our analysis for the long-term positive effects on labor force participation for those with severe mental illness, it may be premature to abandon these efforts altogether. Thus, we recommend that future research assess more clearly defined models based on recently validated evidence-based practices like supported employment and bolstered by established fidelity, which wasn't measured in this study, so that the full potential of early intervention can be more completely understood. Here are the literature citations from my presentation, and I'll end with my contact information. Thank you.
Hi, it's a great pleasure to be here. Judith and I go back a long way with the DMIE. When it began, and even before it began, internally to the federal government, people were working on it, trying to think of the appropriate design, and I was working for the federal government at the time at the Substance Abuse and Mental Health Services Administration. And Judith was running a large multi-site demonstration of supported employment, so we were giving a lot of input and advice to the other federal agencies that were doing the program and hoping to get a lot of mental health involvement, which we were successful at. So it's really interesting to come full circle and do what I'm thinking of as the post-mortem here. To see really, so I have two main questions. What happened? Why did we not get the more stunning effects that we were hoping to? And then second, where do we go from here? So what happened? In my long history as a program evaluator, I got this incredible urge while reviewing this paper to develop a logic model, which I did, but I will not bore you with, although I will bore you with all of the details about what I was thinking about it. So in a logic model, you're trying to think, what is the program theory about how the target population fits together with the intervention that's offered, and how does that fit together with the outcomes? And intermediate to that is the outputs, which are, so you have the intervention as designed, and then the outputs, well, what did people actually get? So I kind of walking through this logic model that I have in my head, starting with the target population. My question is, are these the right people? Were we targeting the right people? So in some ways, it seems like they were the right people. It was designed to be people who were working and not on benefits yet, and they were working age, so those were the right people. The demographics, I'm not really sure about that, or the others here probably know better whether the demographics of this group are similar to the people who are entering Social Security benefits. But the thing that really strikes me is the diagnosis. So we've got two main groups in this study. We've got people with serious mental illness, which is depression or bipolar disorder or schizophrenia. That strikes me as the primary group that has severe enough and chronic enough or recurrent enough mental illnesses that they are the ones that are more likely to end up on Social Security benefits. The much larger group, though, that was 89% of them, were people with, quote, other behavioral health diagnoses and co-occurring physical health problems. So the other diagnoses were anxiety disorders, non-clinical depression, substance abuse. Those don't particularly strike me as people who are at risk, particularly at high rates, for going on to the disability benefits. And the co-occurring physical health disorders, diabetes, heart disease, high blood pressure, I'm not sure about that. That doesn't sound like what I hear about on the disability rolls that much, so I'm not sure. So the actual outcomes of the improved employment suggest that the serious mental illness group was most amenable to this particular intervention, helping them. So that's good. But there was we don't have information about the long-term effects. Well, there was not the effect on the Medicaid disability rate. The other thing about this population of the other diagnoses is that overall, the people in the study were not using many outpatient services. 12% of them or something were using mental health services. So it's like, well, do they have a mental health problem? Because you would think they would be using a lot more outpatient services. On the other hand, there were two results that suggest maybe these are the right people. One is that over this longer term study, 18 to 19% of them did go on Medicaid disability benefit for disability reasons. So that's a pretty high rate there. The other is that graph of the employment decreasing over time, and as Dave Stapleton was showing in his slides earlier, unemployment precedes disability benefit applications. So maybe they're the right people. I'm not sure, but it's something to think about. Then the next question in the next part of the logic model is the services and the intervention. Was this the right intervention? And there was a lot of focus, it looked like, I'm just getting this out of the papers that I've read, on health care access. So, the health care access was, in this case, it sounded like it was more of a wraparound kind of model because everybody was already enrolled or receiving services from this health department that was provided a, quote, Medicaid-like benefit. So they already had a lot of health care access. So there's not a lot of room for improving on that. So they were added, vision care and, copay, paying for copays and things like that, but it seems more marginal. The other thing that's not clear, though, is was there something else other than health care access that was provided here? Because the research in the mental health area shows that just providing people mental health care is not enough to get them employed, that they need more services that are focused specifically on employment to affect employment outcomes. So there was some talk about, motivational interviewing, case management integrated with vocational supports, but I don't know what those actually looked like. And it doesn't seem to have been measured how much of that anybody got. So then was the program implemented as intended? Again, we don't know about the employment supports, the case management, the motivational interviewing, but the increased healthcare access, it seems like, well, okay, they got some additional pharmacy services, not so much on the outpatient and not at all on the inpatient ER. So what that leaves us with the logic model is if there's going to be a long-term effect, it's because of the improved pharmacy or these unmeasured other services. Moving on to the results, the outcomes. I didn't really notice it the first time I read the paper, but I was thinking later that in the outcome models about employment and disability, you controlled for the pharmacy and service utilization. And I'm thinking maybe that was a mistake, because the logic model has the pharmacy and the other services were part of the intervention. So it's like you controlled away the intervention part that we have that would have had the effect. So one of the questions I have, and you may have probably looked at this, is whether in those models, those control variables about service utilization were related to employment or not, and you can comment on that after this. But even if with the controlling of those variables, there was still a significant effect for the serious mental illness on employment. So that suggests to me that it was something other than the medical service utilization that led to the effect. So that makes me ask again, what were those other services that people were getting that seemed to have had this effect for serious mental illness? So now, having gone through the logic model, where does that leave us and where do we go from here? So one of the things we talk about when you talk about preventing job loss and long-term disability and dependent long-term application for benefits and things like that, you have to really think about what is the target population and what is the point of intervention. So here it seems like maybe the group that was targeted was too broad, and we need to find a way to narrow that down. So certainly, narrowing it to just serious mental illness, maybe that's the way to go, although that's a much smaller group. Maybe depression. A lot of the work on stay at work and workplace interventions focus us on depression, but even so, there's a lot of variation in depression. Depression is such a common disorder that most people with depression are not disabled by it, certainly not for the long term, and they have poor employment outcomes overall, as a group overall, but there's still a lot of people that will never come close to the disability roles based on depression. I was also thinking maybe a later point of intervention is needed. So, it's common for people to say, we want to go back further and further and further, get people earlier and earlier and earlier before it really becomes a problem. But in this case, maybe we went back too early, that these people were not particularly at risk of becoming disabled over the long term. And so maybe we need a later point of intervention where people are already experiencing work absences or decreased productivity or use of short-term disability, something like that. I think as Judith said, we also want to think more carefully about what the intervention is in the future, create a logic model to see how is it all supposed to go together, make sure we're measuring the right things, and use a manualized approach so that we know that people are really implementing it in a standardized way, have these fidelity measures to see what people are really getting. Another question about the intervention is whether we're going to keep doing things that are primarily focused on mental health treatment or whether we're going to add these employment support components. And then finally, the outcomes. There's two kinds of outcomes we need to address here, mental health and employment outcomes. So in this study, I didn't see anything about the actual mental health outcomes, whether they actually got better or not, or stayed better or not. In a lot of studies, you see the mental health outcomes, but not the employment outcomes, even in the studies of workplace mental health. So thank you very much for your attention.
Great. Thank you, both the presenters and discussants. We have 9 minutes to lunch. Do any of the presenters want to respond to the discussant comments? Great. I didn't think anything rose to that level. I would be happy to take questions from the participants here on the papers that were presented. Yes. And so hold your hand up, and then we'll bring a microphone to you. I can hear you, but others in the audience probably can't.
Hi, my name is Susan Picerno. I'm from the Office of Disability Employment Policy at the Labor Department. And for the first presenter, I was wondering, you were looking at the cohort of people who had applied for benefits after the Great Recession, but I was wondering if you were able to tease out the people who perhaps were severely disabled and would have applied anyway during that time period, as opposed to the ones that were actually responding to the recession.
So I'm not sure I totally understand the question, but the intention was to try to tease out like who was applying additionally in response to the Great Recession.
Well, my question is, for example, if there hadn't been a recession, X number of people would have applied for benefits anyway because they had significant disabilities. So were you able to distinguish those two groups?
I think so. So the people who were not induced to apply by the Great Recession, one would assume that they would have applied anyway if the unemployment rate had remained at its baseline. That's actually kind of the core of our simulation exercise at the end there. We basically try to net out those who were induced to apply because of the Great Recession, kind of scaling by the change in the unemployment rate. And so those who are left over would presumably have applied, regardless. And then we looked at their allowance rates. So, but maybe we can talk more offline. I just might not be able to understand, sitting up here what you're getting at.
Great. Okay, next question. Yes.
Joanne Schneider again. First paper, which was really great, and David, thank you for those comments. They were really, really helpful. This is sort of a comment and a question about whether or not someone else is, or you guys are working on some additional data. I'm wondering if the focus of the intervention, I've been arguing this for a while, should be on the individuals or on the employers, because I'm thinking, have been arguing that this is all part of a massive age discrimination, disability discrimination, particularly older workers, that started during the Great Recession and continues. And so I'm wondering if there is any data on how or why these folks lost their jobs, and also on another group that wouldn't show up in the SSDI rolls, those who took retirement about this period and why they retired. And then finally, what happens to those who were denied SSDI? Where are they now?
Thank you for that comment. I mean, I think there was a lot there, but it is. I actually, one of the things I really took away from David's comments, besides trying to look more at the dynamic effects, was, the implications of our paper for thinking about, successful reforms to the disability insurance program. He's absolutely right that, our results point to this group of people who do seem, to potentially be able to work in some circumstances, but not in others if they're moved by the economic conditions to apply for SSDI or not. We can do some heterogeneity analyses, and we do. I didn't talk about some of the ones that we did by severity. Age group is definitely a possibility. We can't tell, unfortunately, like how or why they lost their jobs. That's just not, in the data set. Unless there's some sort of clever way to get at that from the applications data, I think that's a little bit lost to us. And it is actually a good idea, I think, to follow up. We can link these to administrative earnings records, and try to look at employment outcomes and earnings outcomes for the sort of induced applicants. So that's a great idea. Thank you.
Andy Arias from the Office of Disability Employment Policy. To what extent is any of this information or the reports being shared with physicians or healthcare providers? It seemed really substantive, and the information, one of the presenters, I think the second presenter, said what a pivotal point healthcare providers played in whether or not individuals were returning to work or getting access to opioids or what have you. So I wanted to know, to what extent is this information being passed along to those healthcare providers?
I'm not sure anyone on the panel can directly answer that question. I do think part of the hope of the Disability Research Center is to make the research more accessible and, kind of just move it out of academic journals and into, and actually, I actually find the booklet that was distributed very helpful in kind of summarizing the papers in a much more concise and accessible format. So I don't know if, that I wouldn't want to declare victory on the basis of that, but I think it's a step in the direction of doing research that is immediately applied to policy questions and that is accessible to the people who would want to use that for decision making. But certainly there's more we can do in that dimension. Any other questions? Yes.
Hi, Stacy Cloyd from NOSCR, and a question about the first paper. I was wondering if you distinguish between technical denials and medical denials when you looked at the sample, because I think if you're trying to figure out the why of when people apply, that's probably an important aspect of it, and the folks who are denied technically may have a different why than the medical folks. I also wondered if you looked at dismissals, which are something that has also increased quite a bit over this time period, and if you had any thoughts about those.
Yeah, so as to the first question, everything that I was telling you about, I probably should have made this clear, is medical decisions. So we don't have technical denials in our data set. The second question, dismissals. Yes, and I wrapped up, just for the ease of exposition, dismissals and denials in the, put the two estimates together, but we do separate them out, and we do see an increase in dismissals, separate from denials.
Can you define that term for us? Dismissals versus denials?
Oh gosh, Alexi, help. He has no microphone, but.
I'm sure there's someone here who can give a better definition than me.
Nope.
It's I think it's that the denial is on the basis of the medical criteria, and the dismissal. I do not know the answer to that, but
maybe the NOSCR represent.
Oh yes.
Oh, we have someone. I believe we have the answers in the audience. This is for the jackpot.
Great, I'm glad to compete. A dismissal is essentially saying that the person has no right to a hearing. There's not a decision that's made on the case on a medical basis. It's that the person is not entitled to that decision.
And that's different from a technical denial, which
yes,
I thought was
a technical denial is a decision. It's a decision that they're not eligible for some non-medical reason. But a dismissal, there's no decision made at all. It's like if somebody requests a hearing, but they don't file the request in a timely manner.
Gotcha.
The case is dismissed.
Understood. Okay, so you are all about to be dismissed for lunch. We will reconvene in 15 minutes where David Cutler of Harvard University will be speaking on health and disability. Thanks very much.